drive safe out there. We hear from the people that have been calling in and have come in to speak on the show that roads are a little bit slick. They're not terribly treacherous. We are expecting, as we look at the weather forecast, the chance of freezing rain this afternoon. And let's take a look. We do have one more school closure to report, or school update. This is a Portland school. Grace Lutheran School and Precious Lambs Preschool, no morning preschool. That's the latest. The frequency of which we're getting school updates is really decreased this morning, so it looks like getting a handle on the situation today. As we take a look at the weather forecast, rain possible today mixed with freezing rain, mainly after 1 this afternoon. So the forecast has been revised that most of the freezing rain expected is going to be later in the day. Yesterday they were saying that we were expecting the freezing rain this morning, late this morning, but now it's looking like it will be here early this afternoon. Total daytime ice accumulation today should be about 1/10 of an inch. Good chance of getting precipitation today, so there's a very good chance we're going to get some rain. It's probably going to be freezing rain because of the outside ambient temperature. So just be aware that this afternoon it could get a bit slick out there. Tonight, temperatures continuing to warm tonight through the first of the coming week. Lows around 35 degrees tonight. We're going to find traditional wet rain falling tonight into the foreseeable future. A 90% chance of showers tonight. New precipitation amounts tonight between 1/10 and 1/4 of an inch. 50-50 chance of rain on Friday. Friday's highs 46. We're going to find daytime high temperatures in the mid-40s. Nighttime lows just above freezing, 33 to 37 degrees. So as we look at the extended forecast all the way through Wednesday, we're looking at nighttime lows about 39, daytime highs about 45 to 47 degrees. So it looks like maybe for at least a while we're outside of this Arctic deep freeze that we've been experiencing the last week, which is a good thing. Stick around, AM 1260 KLYC, and again, let's take a look at school updates, see if we've got any latest updates. We do have one more. Okay, that one is not pertaining to this area. Again, repeating the local ones. Willamina School District, regular start time, all buses on snow routes. And Dallas School District, buses on snow routes. Let's go through a few of the local ones, especially the Salem area, for example. North Santiam School District, Staten, regular start times, following buses on snow routes 11, 14, 26, 28, 34, 36, 40, 42, 43, and 44. Head Start programs, Community Action Head Start, Marion, Polk County, Cascade site, no morning classes, effective today. Falls City School District, buses on snow routes. Cascade School District, 2 hours late, no morning kindergarten. Corvallis Boys and Girls Club open today, 9 to 5:30, $30 at the door. Scholarships are available. Families need to pack lunch and a snack. Corvallis School District. Now, Corvallis has really been hammered by snowfall and slick roads. Corvallis School District still closed. The entire district is closed still today. As we take a look at other districts of local concern, we are finding, as we spin down the list here, Scioto School District, 2-hour delay this morning. The Sweet Home School District, Lynn County, is 2 hours late, no morning kindergarten. Greater Albany School District, 2-hour delay at all schools, no morning kindergarten, morning intervention, no early morning AOS, no senior dinner in Tangent, and Lebanon Community Schools are closed today because of slick roads. So that's what we have for you this morning. If I didn't mention your school, you got to go to school. AM 1260 KLYC, and 7:33 is the time as we're waiting for Thad Brill to call on the morning stock market update. We're going to introduce who we have for guests today here on the program. We have at our studios today, we have, in fact, this is the gentleman we hooked up this program with, Silas Holleran Steiner. He is director of, what exactly is your title, Silas?
Health and Human Services Director.
Health and Human Services Director for Yamhill County. Thank you for being with us on the program today. Yamhill County Care Organization. We're going to talk about what a care organization is, and Jim Carlo, the executive director of that, is in the program and on the program today. And we're also going to get the perspective of his physician. Jim Rickards is a physician and a local radiologist, and is in fact a board member of the Coordinated Care Organization, or County Care Organization, here in Yamhill County. So, gentlemen, thank you for being on the show. Looks like our stock market report is on its way in, so we see it in the queue, and we'll be able to... There we go. AM 1260 KLYC. Let's go to the phone lines. And Thad Brill. Good morning, Thad.
Well, maybe Kevin Gebhardt this morning. How are you, Dave?
I didn't get the memo.
Okay. Remember that Thad's going off to the football game.
Okay. Hey.
He's going to go watch that Army-Navy game. There's a lot of tradition there. So I think it's wonderful he gets a chance to go.
I think it is, too. So how are you doing this morning?
Doing just fantastic. Beautiful morning out there. All the frost on the trees and fences and cables really looks beautiful.
Yeah, it does. A winter wonderland, isn't it?
Yes, it is. Not a problem driving at all, though.
Good. Yeah, and it's starting to warm up, and that feels pretty good. I don't know about you, but the bitterly cold temperatures were something that I grew up with over in southwest Idaho, and I'm kind of glad that I don't have usually over here in the Willamette Valley, so it's nice to get back to more normal weather.
That's true. A couple, 3 days ago, it really did seem that it was just bitterly cold, where just yesterday it was just chilly. And the same way this morning. So I think you're right. The bitterness is gone.
And amen. Thank you very much. So what's going on in the stock market?
Well, let's look at yesterday real quick. Flash you back there where the Dow Jones Industrial Average was down 129 points, S&P 500 down 20, and NASDAQ was down about 56. This morning, U.S. stocks are starting lower following the biggest drop in equities in a month. We're looking at utilities gaining, otherwise based retreats. Right now, the Dow Jones Industrial is down 70 points at 15,773. S&P 500 down 3 points at 1778. We have NASDAQ positive by 2 points at 4,006. We do have our decliners outpacing advancers, roughly a 2-to-1 margin. Looks fairly light this morning on our volume. We've got 173 million shares trading hands on the New York Stock Exchange. So look at a couple of stocks of local interest. Boeing's up 2 cents at 132.58. Intel up 21 cents at 24.63. Nordstrom's off 14 cents, 60.65. Schnitzer Steel's down 15 cents at 29.79. Apple's up $1.64 at $563 even. And Nike's given back 46 cents at $76.14. If there's anybody out there that would like a quote on an interest rate or a stock, they can sure give me a call at 503-472-0234. This is Kevin Gebhardt with Edward Jones at 833 Northeast Highway 99W right here in McMinnville. We are members of both the New York Stock Exchange and SIPC. That stands for the Security Investor Protection Corporation. We sure enjoy giving you this live report right here on KLYC. So, Dave, thank you so much for letting me set in. And, Thad, thank you for letting me set in and have a great time at the football game.
Okay, and I hope, which team is he rooting for, do you know?
Oh, go Navy
go
for
Navy.
That, of course. Yes.
Okay.
Absolutely. I think there's a pretty big Navy background in his family. Son TJ's in the Navy currently. And I believe, I'll have to ask Thad for sure, but I believe his father was in the Navy.
All right. Well, go Squibbies.
Yeah, I think that's right. I guess they're midshipmen. Is that right? The folks that are in school, and then the Army folks are cadets, I believe.
Correct.
Okay. Gosh, I got lucky on that one.
You got lucky on that one. Well, go. I hope the Navy gets lucky, and it's all skill, right? That's what Thad will say. Oh, it's all skill.
Oh, absolutely. I think it's wonderful, the pageantry that they have there when all of the underclassmen come in and the upperclassmen come in. I'm sure they have quite the military flyovers and everything else.
Okay, well, go Navy, anchors away, and bring home the hardware.
Absolutely.
Okay, you have a great day.
You also, Dave. Bye-bye.
Bye-bye. Drive safe. AM 1260 KLYC, and glad you're with us today. Cup of coffee this morning. We're going to be talking about the future of healthcare in Yamhill County. And again, guest today in the studio, Silas Huller-Steiner, Director of Health and Human Services Department for Yamhill County, and Jim Carlo, Executive Director of the Yamhill County Care Organization. and Jim Rickards, physician, local radiologist, board member of the CCO. Gentlemen, thank you for being with us here on a Cup of Coffee this morning. Silas, I heard you give a presentation to the, and talk a little, if you would, Silas, talk on that mic. No, you were right there. And yeah, go ahead and pull that one over to you. Don't you love live radio? And Silas, you gave a very interesting presentation to Yamhill County Commissioners. I think people are hearing so many, they're hearing so much of the foibles as far as the statewide Cover Oregon program, that the computer programs aren't working. The Obama administration is really taking it on the chin for the rollout not going well, the website's not working well. So I think the perception from a lot of people is they can't sign up and it's not working. Could you kind of define where we are, at least specifically Yamhill County? What's going on? A care organization, the Yamhill County Care Organization. Let's talk to Jim Carlo. What is the Yamhill County Care Organization?
So, good morning. The Yamhill County Care Organization is a new grassroots organization that was formed in the community in response to the governor's and the legislators' intent to redesign the healthcare model for Oregon Health Plan in the state. And it was it started with House Bill 3650 and an attempt with the governor working with Obama, President Obama and the White House and his staff to come up with a solution to help contain costs around the growth and the trend of healthcare costs in America. So it was part of the waiver that the CMS and Oregon State negotiated, and contains a lot of new requirements for the health plans to make sure that community is involved. And some of the new designs include having a clinical advisory panel to the board of directors, as well as a community advisory council, which consists of 51% of consumers. So we get that direct consumer voice.
Let's talk to a physician. We have a physician in the studio. Jim Rickards is a physician, local radiologist, board member of CCO. Jim, I was talking earlier in the show about the trend that we're on as far as access to healthcare, the cost of healthcare. A lot of consumers are simply avoiding, especially, well, you're a radiologist, so sometimes the mammograms and so on and so forth, the preventative measures, so to speak, are very cost effective because you find a problem early on and then you treat it and you don't have the expense. And we're seeing a lot of people delay that. The system, would you agree with the statement that the system is broken?
Yeah, well, thanks for having me. You know, a lot of people say that the healthcare system is broken, and I think really what we have is kind of a failure of the payment and the kind of the administrative and delivery system. You know, I think there's a lot of great healthcare being provided out there. We don't have, you know, people just dying left and right. You know, I think there's a lot of great medicine being practiced. Providers, physicians are very passionate about their job and really care, but I think where, you know, that failure or broken piece comes about is the fact that, you know, it's difficult for people to obtain coverage and it's difficult for people to understand what their benefits are. So when people say the system is broken, you know, I think it's that kind of the payment and delivery side. And the exciting thing about an organization like the Yamhill CCO is it really brings together all parts of the healthcare system. You know, it brings together the payer, it brings together the providers, and it brings together the patients to work together to try to figure out solutions to that problem so, you know, we can fix that kind of broken system. So what we've done is really kind of create what I consider a community health plan to serve our Medicaid members, you know, where we have physicians, patients, and then the payer all at the table working through problems. And, you know, I think one of the big values of that is that when a problem arises, you know the people you're working with in an organization, you can quickly address it. You know, and I've seen, you know, some results of that kind of model in place. You know, for instance, we had some issues with some of our patients getting a special medical device earlier that they used to be able to get from the pharmacy, but there was kind of a breakdown in the system, and because all the patients, providers, and the payer all sit at the same table, we knew who to call and who to contact to kind of fix that problem and work through it. So.
Now, to talk to this question for Jim, do you think maybe there's a perception? Do you think maybe there's a wait-and-see perception from the public because they're hearing all of this about the websites don't work, and so they're kind of waiting for it to play out to decide exactly what to do? They're hearing time and time again news reports of, for example, Cover Oregon. that people can't get signed up because the website's not working. Are people just, you believe, just kind of waiting for the other shoe to fall before they do something?
Yeah, I don't know. I mean, I think the message has been a little bit confusing for the public, and Cover Oregon or any health exchange is certainly a vehicle to help people get signed up for health care and help them determine whether or not they qualify for the Oregon Health Plan as well, which folks in Yamhill County would then be served by the Yamhill County Care Organization. But aside from the technology challenges that the state and the federal level has had, there's still a manual process occurring. And I do know through my interactions with the Oregon Health Authority that they've got over 500 people staffed to do manual applications. So people are getting enrolled, even through the technical challenges. But we hear that that December is looking better in terms of access and for the website.
Could we take this and define it to the lowest common denominator? Let's break it down in layman's terms so people understand. The Yamhill County Care Organization is providers, patients, and insurance companies, correct, working together to deliver health care, correct?
It is, yes.
Okay, let's define that. Let's take it down to layman's terms. Exactly what are we talking about here?
So if we look at the board of director composition first, I think we've got both of the hospitals participating, Providence Newburgh Medical Center, Willamette Valley Medical Center. We've got Health and Human Services. Silas here is our board chair. So we've got direct input and partnership with both public health and mental health, which is key. We've got representation from Care Oregon, who is an infrastructure partner with the CCO and helps deliver the administrative services for the physical health benefit. We've got Mid-Valley Behavioral Care Network representation, who helps us administer and works closely with Yamhill County Health and Human Services on the delivery of the mental health services. We've got local physicians, we've got community advisory members on the board. So really it's this community conversation about how we deal now with the global budget for services and how we think about them in terms of a health commons, and make sure that the budget is sustainable for the year and that we're paying for all of the right services at the right place at the right time.
What are we wanting people to do now? There's a lot of, as you drive by an insurance company, there's one particular here in McMinnville, you drive by and there's sign up now, there's like 5 signs out in the yard, in the lawn, come in and sign up for Cover Oregon. What do people need to do now?
Yeah, I think it's important to understand that the deadline of December 15th, part of the Affordable Care Act is a mandate for health insurance coverage. So if you're not covered currently through an employer or your own individual policy, there's a requirement to sign up for coverage. Through that process, individuals will be able to determine whether or not they qualify for the Oregon Health Plan or any federal subsidies to help them cover the costs of that insurance plan.
So they have to be signed up by December 15th, which is 3 days away.
Well, and enrollment will be ongoing. So I think just pull the lens back from Yamhill County just for a moment and look statewide at Oregon. Some of the numbers that the governor's office and the Oregon Health Authority have put out show the following. Just statistically speaking, today about 83% of Oregonians have some type of health insurance coverage. And by 2016, they project over 95% of Oregon will have some type of health insurance coverage, and that's really coming into 2 main populations, either the Medicaid, the Oregon Health Plan members, about 240,000 new individuals will be covered through that process, and then through the health insurance exchange, which is through Cover Oregon, is the platform that really links people to individual commercial plans. There's another 250,000 projected there. So when you look at the state's plan for the Oregon Health Plan, we're looking at possibly 1 in 4 Oregonians having Oregon Health Plan coverage. Today, that's about 650,000. So if you add the 250,000 to that, you're getting close to 1 million Oregonians. And locally, we would see a similar projection. So today, we have about 17,000 individuals out of our 100,000 that live in the greater Yamhill County geographical area. And by 2016, we'll see that number grow to 23, 24, possibly 25,000 individuals. So that would make 1 in 4 Yamhill County residents on the Oregon Health Plan with this local coordinated care organization, Yamhill CCO.
So we're looking at a December 15th sign-up deadline, or now you mentioned that the deadline is somewhat rolling or can be varied.
Yes, enrollment will continue. It'll be ongoing. It's just to be enrolled and covered by January 1st, 2014, you'd need to be signed up by December 15th.
And if you're not signed up by January 1st, you face the penalties. Is that correct?
That's my understanding, yeah.
Okay.
So I think that the way that the ACA, the Affordable Care Act, has set up the penalty in the first year, I think it's $95, as I recall. I think that the enrollment process is going to be extended. In fact, I know that in Oregon they're already changing some of the provisions, and they've done some things nationally too to allow people to stay on their plans. That's one of the big pushbacks that at least Congress has been having a lot of conversations about that. And again, not to dive into a national debate around was this a good idea, which parts are good, which parts aren't working well, because I think there's a lot of differing opinions around that, as there should be, and some real scrutiny that we need to look at. Hey, how is this really going to serve America? Locally, the opportunities for community coming together, defining problems, and coming up with solutions is alive in this Yamhill CCO model, and we're excited about it because, really local, all healthcare is local, and to put power back into the consumer and the physician and the provider base that's delivering care really is a value add right now, and we had a legislative process and a governor that put some focus on local communities that we think there's going to be an opportunity here to do that.
So one of the nice things about this happening now is we're starting to have dialogue from physicians, from providers, from insurance companies, from consumers. Everybody's coming to the table and saying, we have to do something here. And part of the CCO, the Coordinated Care Organization, is this dialogue occurring? Good thing?
Yeah, absolutely. It's a great thing. And, from my perspective, I've been in the healthcare industry for over 20 years. On the health plan side, and typically I think, and I think everybody would agree at the table today, even just the silos that we've been operating under over the last, well, you pick the years. It's been going on for quite a while, and what this does is it allows us to start working inter-organizationally and breaking down those silos. So as Dr. Rickards mentioned, we're able to have some really unique conversations in the same room with partners to solve issues that would have taken maybe years to solve previously because we just didn't have the relationships or the forum to have that discussion.
Yeah, and in my mind, what I've seen is this community really has been able to come together under the umbrella of the CCO and really start to talk amongst each other in ways that's never happened. For instance, I practice at Willamette Valley Medical Center. We're fortunate to have 2 hospitals in this county. I never really had spoken much to the physicians or the administrators at Providence Newburgh, and now on a regular basis we get together and talk about local health care problems, and how we can provide better care for our patients in the county. And not only with other physicians, but also able to reach out and speak with other community organizations. For instance, we've been able to build what we call a community hub or high utilizer program, where we reach out and try to proactively help individuals that have a high number of emergency department visits and try to get them tied into a primary care provider so they can get more regular access to care, to get those preventative services so they don't have to go to the emergency department. And it was through those relationships that we were able to build with our community partners that we've been able to develop programs like that.
Is that a good example? Now that you kind of answered my second question here, let's give some examples about how the Coordinated Care Organization works. Is that one example of how it works?
Yeah, so that's one of the kind of the projects we put in place. We put in a number of projects to kind of transform healthcare, to meet the so-called triple aim of providing better health, better care, and lowering costs. So that community hub program that I just mentioned was one. Another program we've supported is the embedded behaviorist program. So we've taken master level psychologists and embedded them or placed them within physical health or primary care offices. So if patients come in with a physical health problem, oftentimes they also have a mental health problem or behavioral health problem that they can't really get addressed by their physical health provider or by their physician, but might need some, mental health expertise. So what we've done is support the placement of individuals, the master level psychologists, in the doctor's office. So if individuals have issues with depression, anxiety, or substance abuse issues, they can get the care right there at the same time they're seeing their physician.
So the coordinated care organization, I think some people might have the misnomer that if we're talking about a CCO, we're not talking about building a building or having a new hospital, so to speak. We're talking about the players coming to the table and really coordinating the care, just as the name says.
Yeah, you're absolutely right. It's not the intent is not for new brick and mortar
Right.
and infrastructure. It's about conversations. And so several months ago, I was participating in a CCO conference, and I was sitting at the table with a few legislators who were getting ready to go up on stage for a panel discussion, and one of them had asked me if I could summarize the CCO effort in one word or less. And of course, one word, is a challenge.
How do you do it less than one word?
I don't know. So I pondered that for a little while, and when they came back to the table, the word that came to me was permission. And I think what this policy has done is given the community permission to talk and come together and think about better ways to coordinate care. And it's been effective. We've seen some pretty amazing things happening across the state.
Yeah, and with that, I might add that my single word, I think that's a great single word, but my single word to sum up what it is would be relationships, because I think that's really what we've been able to build. Silas, for instance, works in the county and does a lot with Health and Human Services, which is really in line with what I do, every day as a physician. I deal with individuals' health and, their humanity. But 2 years ago, I didn't know who Silas was or what he did or what his office did at all. But now we, converse regularly and work through a lot of problems and really are helping to coordinate the efforts of the hospital and the county as well as, other stakeholders to improve care for our community.
I think one of the things that this does is what was happening, I believe, was the right hand not knowing what the left hand was doing, and so the left hand would go out and buy something or do something, and I think there was a lot of repetition, a lot of duplication of services. And I think we're looking at part of that in the coordinated care is helping to drive down the cost, saying, okay, what tests have you done? What's been going on here, and what can we bring to the table? What can you bring to the table so we're not duplicating services and procedures which are driving up costs?
Yeah, you're absolutely right. And I think we'll get to this later on perhaps around challenges, but maybe if I could jump the gun a little bit.
Go ahead.
So I think one of the challenges for all CCOs is data, because we're bringing together new organizations in ways that they haven't communicated previously. We're looking to overcome that through a health information technology product that will allow us to connect all of the electronic health records and extract pertinent information, which would allow physicians to get real-time information on test results, regardless of where they occurred within our county. So to your point of redundancy, I think, if you have somebody that had an MRI done 6 weeks ago and gets referred to a specialist and they don't know that MRI occurred, they would likely order another one. And so with our goal of bringing the electronic health record information together under this technology would give us real-time access in looking at when tests were ordered, what the results were, and also give us a lot of information regarding diagnosis and continuity with treatment plans. So that redundancy and coordination starts to really get amplified at that point.
Now we might have some people listening to the program this morning that say, well, as they look at their monthly budget, it's really tight. Maybe they're underemployed or unemployed, and they would like to have health insurance, and they like what we're talking about reducing costs, reducing redundancy of services, so on and so forth. But they say, yeah, I'd like to buy into this. I'd like to get involved. I'd like to get involved in the conversation, but also have affordable health care. But I can't afford it. I can't afford, $200 a month health insurance premiums. That's, I guess, where the subsidies might possibly come in. So what would you recommend to those folks is to get into an insurance office somewhere that does the Cover Oregon and sign up, or at least put in an application?
Yes, absolutely.
Yeah, I think Hagen Hamilton has offices in West Valley, New Bergen, McMinnville, and I know they're doing the Cover Oregon enrollment, and that ongoing. They'd probably be a resource for individuals that might be eligible for the subsidy. Eventually, the website will be up. It's a matter of it's not a matter of if, it's a matter of when. I do believe that will get up and running, and that'll give individuals more opportunities to look from their home or the library or wherever they have internet access and be able to compare and contrast some of the plans. That's how the health insurance exchange is supposed to work, so that you can actually see side-by-side comparison of what the cost would be to the individuals. If you're eligible for the Oregon Health Plan and you know you meet those income requirements, and you can go onto the Oregon Health Authority's website to see what some of those basic income requirements are, then there are 2 locations I know of, and possibly I think a third. Help me out here if I missed one. So Virginia Garcia at the Memorial Health Center here in McMinnville, and also the Housing Authority of Yamhill County. I know they're processing applications for Oregon Health Plan membership now. So they'll do a paper application. It's not through the website yet.
I think a lot of people are just trying to get their minds wrapped around the terms when we use terms like coordinated care organization, health insurance exchange. Health insurance exchange, as I can try to say it this morning, is essentially a way for you to look at apples versus apples. You can say, okay, this is this kind of coverage, and in the past it's been very difficult for people to shop around for health insurance because we didn't understand the terms and how does this policy compare to this policy. The health insurance exchange, as I understand it, is a way for them to actually look at it like a shopping list and have everything kind of match so you can compare it apples to apples.
Correct.
Yeah, absolutely. It's an online marketplace for all of the health insurance products that'll be offered to individuals, including government programs like Oregon Health Plan.
Is that available online now? Do we need to go to Hagen Hamilton and look at something they have, or can we find that online?
So online at the Cover Oregon website or the Oregon Health Authority, there's a lot of information available on those 2 websites. Again, I think, I don't know what the current situation is with the online enrollment process, but Hagen Hamilton it can certainly help folks navigate some of the opportunities and options for them to select healthcare coverage. And then, like Silas mentioned, if individuals already know their income requirements and eligibility and know they may qualify for the Oregon Health Plan, they can work directly with Virginia Garcia or the Housing Authority.
We just got an update. Scioto School District is closed, and let's take a look real quickly and see if we have any others. That's the only one that's a new one we have. We're going to continue this conversation for the next 30 minutes. If you have a question that you would like to have posed to the group, we're not taking phone calls, but we are taking email. And you can email a question to news@klyc.us, news@klyc.us. In the studios, we have Jim Carlo, Executive Director of the Yamhill County Care Organization. We're going to define that a little bit more, exactly what that is and what's being done locally. Part of that conversation also with Silas Holleran-Steiner, Director of Health and Human Services in Yamhill County. And also Jim Rickards, from a physician's perspective, he is a local radiologist, board member of the CCO, and also works at Willamette Valley Medical Center. This morning we're talking about healthcare here in Yamhill County. In the studios today, by the way, if you missed the show, you want to listen to it again, we'll have it posted to our website. Just go to the YouTube link at the front page of KLYC.us, click on it, and it'll be the interview at the top of the page. We should have that posted this afternoon before noon. In the studios, Silas Holleran-Steiner, Director, Health and Human Services Department for Yamhill County. Jim Carlo, Executive Director of the Yamhill County Care Organization, and Jim Rickards, a physician, local radiologist. He's on the board of the CCO and also works at Willamette Valley Medical Center. So, Silas, let's talk about primary care. What's going on there, how to pay for it, just how that looks going forward.
Yes, so one of the big commitments that our board of the local CCO has made has been to strengthen how we pay for primary care in the community here. And nationwide, this is a big issue for us because if we don't start to incentivize and pay for good, high-quality primary care and preventative medicine, that's part of the challenge with today's sick care system, is that if people don't have access to those primary care services, they can end up possibly missing diagnoses that would be early on, that could be preventative, that could keep them out of high-cost, care that at some point they're going to end up in the hospital system. And really it's about a quality of life issue and about overall community health outcomes being increased when we do good preventative medicine. So at this point, the board has, in the first year of operation, we've been in operation since November 1st, 2012. We just experienced a one-year anniversary, and we've been able to strategically set aside some of the funds that we've saved through better utilization and being careful about some of the spending, because remember, a coordinated care organization ultimately is functioning like a health insurance plan and is responsible for the overall global budget of the members that we serve. And we've set aside some funds, and we're already currently have rolled up our sleeves and are working with pretty much every primary care practice across Yamhill County to come up with a reinvestment strategy that'll start in January 2014 that starts to pay them more for the care they provide today, knowing that Medicaid and Medicare reimbursements haven't covered the true cost of care for primary care for many, many years. That's a fact. And also to start to pay them differently, not just more per episode of care per individual fee-for-service episode, but to start to do some different types of payment that will allow them to build care teams and have other individuals to support the primary care provider and get really the higher quality outcomes that we want to have. And I think Dr. Rickards, probably from a physician's perspective, could expand on that.
I'd add that not only are we just looking at ways to increase the reimbursements or the payments that we make to providers, but we're also looking at ways to help support them. There's this whole concept now that when you go to see your doctor, you don't just go to see your doctor anymore. You go to see a whole team of people that are there to take care of you. So what the CCO has been doing is helping foster the development of that team-based approach to care. So, I kind of already mentioned two programs, a community hub and the behaviorist program that we've done to kind of support that team-based approach to care. Because oftentimes when you go to the doctor's office, it's not just a physical health problem that you're dealing with. It's not just you have high blood pressure or maybe your blood sugar's out of whack because you have diabetes. You might have a behavioral health issue, or you might have a social issue that you need help with that are real issues that affect your physical health, but your doctor isn't necessarily equipped to handle. It's just not his training. It's not his background. He doesn't have the resources. So what we've tried to do is put those resources in the community and place in physicians' offices to help address those other areas that can impact somebody's physical health. And, one more example along those lines is we supported the placement of what's called a care coordinator in one of our largest primary care clinics here in town. And this is an individual who does many things, but among them is she reaches out to all the patients of this particular clinic that have gone to the emergency department the day before. She every day receives a list from the local emergency departments that shows which of their patients have gone to the emergency department, and then she'll call these individuals and find out, well, why did you go to the emergency department? Why didn't you come to the primary care clinic? What was the barrier just to coming to see a regular doctor? And I'll give you one success story from that.
Sure,
I was speaking with the care coordinator, and she told me the story of twice in 1 week a father had brought his young son into the emergency department for a fever. Well, she went through and looked at the medical records and the discharge notes and what was done, and it turns out each time the child was in the emergency department, he wasn't given any treatment. It turns out he didn't have anything wrong with him. It turns out he didn't even have a fever. She called up the father, developed a relationship over the phone, started talking to him. Turns out the father's wife was out of town. He was taking care of the child. He wasn't as experienced as, in parenting as his wife was, and he thought his son just felt warm, and he was nervous, and he wanted to get the best care possible. So the only thing he knew to do was to take his son to the emergency department. He didn't have a thermometer. He didn't really know what the appropriate use of primary care services were. So the care coordinator at the primary care clinic was able to talk to the father, educate him as to what a fever is, help him get a thermometer, and now the next time when the father has to take care of the child and the wife's out of town, he'll know what exactly to do and won't be, perhaps using the emergency department as he had in those cases. So that's kind of a real success story of where that team-based approach to care has really, helped improve outcomes and decrease costs. I think in the past, before that care coordinator existed, probably nobody would have reached out to that father. He would have just would have kept going to the emergency room week after week. But then with this care coordinator in place, we were able to proactively reach out to him and help educate him and get the thermometer that he needed.
Interesting story, kind of a simplistic story, but I think it kind of points to the overall thing. And one of the major issues with healthcare is the emergency room is turned into the catch-all. You know, the center drawer of your desk is always where you throw everything that you don't know where to go. Well, that's what the emergency room is turned into. Is I don't know, the kid's sick. I don't want to die, so I'll just go to the ER.
Yeah, that's exactly right. And you know, part of the issue is we do have a shortage of primary care providers in the U.S. and in this county. You know, we just don't have enough access to care. But by building this team-based approach to care, by putting, you know, other services, other individuals in place to kind of help physicians manage their patients, you know, we can increase the amount of access that we have without necessarily, you know, needing to increase the number of, you know, doctors we have.
When we were off mic before, while the news was playing, we were talking about, you were mentioning the three main elements of care. Let's talk about that a little bit.
Yeah, so when you think about your health, you think about, well, you have your physical health, then you also have your mental or behavioral health, and then you also have your oral or dental health. And those are, you know, in my mind, and I think, you know, in probably most people's minds, those are the three main components of your overall health. So what the CCO is really trying to do is trying to work on all three elements of your health. You know, not only do we work with physical health providers or physicians, but we also work with behavioral health providers. And soon, starting in July, we're going to start working with dentists. And so when we think about those three elements of health and getting the best outcomes for our community, you know, you really got to coordinate the efforts on all three fronts, and that's really, you know, what we're doing here.
Silas, we were talking about the difference between health and healthcare. I think it's a good opportunity now to talk about that. Let's define that. What are we talking about? Health and healthcare. They're actually different, but they're very closely related.
Well, it's one of the things from a public health standpoint that I'm most excited about is helping our community, not just the members that we serve through the Yamhill CCO, because remember that's 17% of the Yamhill population, but really helping the community have a broader conversation about health. So healthcare or medical care really only impacts 10% of your overall health and wellness and how you go about living and experiencing your life. And as much as it is absolutely critical that we redesign healthcare delivery systems, we must really start talking about all the other things that impact health. And so 30% is the genes that you were born into, or the hand that you were dealt, and the other 60% is lifestyle, behavior, social, and environmental forces. And the biggest majority of that 60%, about 40% of that, is the lifestyle behavior. So what we're really starting to do is have a conversation at a community level about how do we start to build health education and health promotion into the education systems, into all the different areas of living where people have a choice to make about what they eat, how they behave, and really what kind of opportunities are we giving young people, especially young people, to learn healthy lifestyles before they get to a point in their life where they develop a chronic disease or have high-risk factors going on that would impact their overall health. And the reason why the CCO wants to think about that is because the most costly healthcare expenditures are often with some of the chronic diseases which are absolutely preventable. We know that a child that's born into with a significant issue and has to go up to a neonatal intensive care unit at OHSU is going to be a cost to the CCO, and we're going to pay for and get the highest quality services for that family that we can provide, assuming it wasn't a preventable prenatal issue. But there are things like that. There are the head-on collisions on Highway 18 that are going to happen, and they're going to come into care, and we're going to pay for that. But to the extent that we can start to look at preventable chronic disease as a core part of what we need to do at a community level to improve quality of life and decrease overall healthcare costs as a nation, we can do that right here, and we can do it by engaging in this conversation about health versus health care, so that the doctor appointment isn't the solution to that person's life. The doctor is a key part of educating, a key part of keeping someone healthy, but it's what that person does when they leave the office and in between appointments that's really going to be critical in defining their health.
Let's take an example. Let's say we've got a guy that sits in his easy chair with a bag of chips and a six-pack of beer every weekend, and that's how he spends the last 2 decades of his life, every Saturday and Sunday. That's what we're talking about, healthy lifestyles. And then this person develops heart disease. When the best way and the most efficient and cheapest way and less painful way to do it would have been to get off the chair and run around the block a couple times. So I know it's a simplistic example, but what do you think?
Yeah, I think that's a great example. And, a few months back I was having a conversation with somebody about the CCO, and they asked me how things were going, and they were like, well, are you saving money? Because it's all about the money, right? And I'm like, well, I think the money is part of it, but really what we're trying to do is provide better care, better quality of care, more access to care, and improve the health of the community. And with that, then you'll start saving dollars. So, when I think about the CCO, the conversation about the finances and dollars is important, but it really first starts with, how can we improve the health of individuals and the care we're giving them. And I think with that in mind, and if you start, messaging that, then you can work on ways, to get that guy out of his easy chair and exercising, and, get him involved in some community programs. What would be, perhaps some community-wide exercise program, or you can put in place, one of the other programs we have is the Peer Able program. It's a peer wellness support program. So, peer support is a somewhat new idea, and basically what it is that individuals that are faced with different conditions such as chronic diseases like diabetes or hypertension, live with those diseases, and they know the most about them. They know how to manage them. They know what local resources are available to help them manage them. And there's some individuals in the community that live with these chronic diseases that have kind of become their own experts at managing them, and they want to take that knowledge that they have and they want to share it with other people and give them kind of some peer support and develop a peer relationship. So what we've done is support a program to help foster those relationships. So when you talk about the guy in the easy chair with the six-pack of beer and the chips, something like perhaps the peer support program, like a peer exercise support program, would be something that he could be involved in.
That's very interesting, because I think sometimes, and we've all had the relatives that have got these issues, and they spend so much time on the internet, which is vast information of knowledge, and they actually become somewhat expert at it, and they go in and they tell the doctor what's going on. And I think sometimes in the past it's been a doctor-patient kind of an adversarial role, where the doctor feels somewhat challenged by this person coming in and telling him how to treat the disease, or the condition. But what you're saying here is these peer support groups are a way where that information base becomes an asset and plugged into the overall way that the operation works.
Yeah, exactly. There's many patients that live with chronic disease that become very knowledgeable on how to manage it. They've already been through all the medications. They've seen all the different specialists in town, and they have a tremendous knowledge base that they can share with others. And that's what the peer support programs do. So.
A couple things we want to talk about. We might run a little bit over time. You guys okay to go past 8:30, or you got time? Okay. Primary care solutions, how to pay for that. Silas.
Well, we talked earlier about some of the key things that the Yamhill County Care Organization Board has invested in, and primary care certainly has been one of them. I mean, ultimately, we want to get to a value-based purchasing, not a volume-based purchasing. So the future models, I think, as individual clinic practices or even larger health systems evolve around alternative payment, will be to pay on a per member per month, so that if you have a member enrolled at your primary care clinic, let's take the largest independent practice here in town, Physicians Medical Center, PMC, if they have a certain number of assigned members, then they will be paid a monthly amount to cover all of the primary care for those members. And then the clinic can start making choices about, do I need to spend an hour with this individual because they have so many different issues, and I just know that this individual is going to need more time because of how they work and they have questions, and I can't really squeeze them into that typical 15-minute appointment? Or would I not need to spend time with this other individual, where I can have a care coordinator, a nurse case manager, do some outreach, or maybe spend some time in the home with them, or do some community education or a wellness class or nutrition class? So that team-based model of care, you're actually paying a lump sum to the clinic to manage the total care of the primary care service array. And with that comes some key quality metrics and measures that we'll be making sure that we monitor, so that we can actually see that care is being improved. Now, that's a very different payment model than today's every lab you order, every test you order, you're going to be paid for every visit, every type of diagnosis. There is so much waste in today's system just from an administrative standpoint. And if you talk to any provider, whether it's oral health, behavioral health, or physical health, they're going to say, hey, I got into this to change people's lives. I got into this to care for the community. I want to care for poor and vulnerable populations. I'm committed to that type of model of care, but I can't deal with all the regulation, and I can't deal with all the administrative burden, and I can't deal with the poor payment reimbursement. So what we're trying to do locally is say, hey, let's have a different conversation. Let's include the voices of the people we serve. Let's include the good ideas of the providers that provide the care, and then let's come up with a model that's going to actually achieve the triple aim: better care, better quality, and better health at lower cost.
So what you're talking about is almost like a sports club membership instead of paying $125 per doctor visit.
Yeah, so like Silas is saying, you get this fixed monthly payment for your members, and as a provider, that's just huge for me. Oftentimes, when I'm talking to patients or helping patients make decisions about well, should we get another ultrasound or a mammogram, or should we just move to a biopsy? How do we manage something? Unfortunately, a lot of times that cost is the main driver of their health decision, and to me that's where a lot of emotion comes into it for myself and for the patient, because you really want the best care for your patients, but then a lot of times when you have the costs and the finances dictating it, that those decisions can become very challenging and make it very hard on patients. If say you're a woman dealing with a breast mass you're feeling and you want it taken care of, but you have the whole cost issue on your shoulder, then that could negatively impact your experience and perhaps the care you get. So I think under this new model, it's something that is going to allow us to better work through those situations and provide better care.
Let's talk about how we're transforming the system with the Yamhill County Yamhill Care Organization. What's going on? How is this looking, and how is this being transformed? How are we transforming the system here? Let's take a closer look at the Yamhill Care Organization. What's happening there? And I guess this question is to Jim Carlo, Executive Director of the Yamhill County Yamhill Care Organization.
Great, thanks. So, I think what you're hearing are some really key examples of community coming together and redesigning the healthcare system. Even with the primary care payment model change, moving from a volume-based to a value-based payment, that's been designed by community physicians and leaders. It wasn't designed in a boardroom somewhere and dictated to the community how it's going to look and feel. And I think that's a very powerful example of what community care and coordinated care starts to look like. And then I think the other key example, really is the relationships. Back to Dr. Rickard's one-word sum of coordinated care relationships. It's knowing who to contact for that handoff and that referral, particularly between primary care and behavioral health or mental health for those services. Whereas they may have not been referred to those services, and that individual was left on their own to try to navigate the system. We've now got team-based care models starting to be deployed that can help the individuals navigate. And then with the Community Health Worker Hub, these are individuals, non-clinical, non-licensed, but just community folks that understand the system, have real-life experience of navigating healthcare, can emotionally connect with these individuals and help them navigate the system and be that support role. There's two. There's the Project ABLE model for peer support and peer wellness, and then there's the community healthcare worker, where we're really starting to engage people that have some pretty severe chronic conditions and get them navigated in the healthcare system. So really, it's this fabric of community coming together to manage the overall health and wellness of the population that we serve.
So again, I asked this question earlier. People hear what we're talking about. They say, yeah, I'd like to spend $100 a month and just be covered and go to a facility and get taken care of. Obviously, that's a lot different than what we're doing today. They like what we're hearing and saying today, and they want to get plugged in and sign up. What's the first step?
Well, so one of the things I think that's important to do is the health care system is extremely complex. And, we sit around the table, and most of us are paid to do this 100% of our time, and we sit around the table scratching our heads trying to understand how to navigate the system as professionals working in it. And just to sort of validate for the listeners out there that the complexities in trying to navigate the system are hugely significant and real, and there are lots of barriers. And the things that we're talking about, some of which are changes that are happening today, and care pathways are being built differently today, are real, and then a lot of what we're doing is planning for the future. And so this will be a model of care evolution over time. But the one thing that I think is really critical is we're talking about the 17,000 members that we serve under Yamhill CCO today in Yamhill County. And that's 17% of the population. So these are the Oregon Health Plan members currently eligible. That's going to grow over the next couple of years to close to 1 in 4 residents. But very, very important is we're making investments on the Oregon Health Plan side that are changing models of care across other commercial payers. So when we make an investment into the Virginia Garcia Memorial Health Center that does community health for another population that's underinsured, uninsured, and it does have commercial payers, their models of care change. When we support the hospitals changing how they care for the Medicaid population, that starts to impact Medicare and commercial payers. When Physicians Medical Center has a care coordinator or a behaviorist working in their primary care practice, that's for all pediatric patients. It's not just a Medicaid population of the Oregon Health Plan. So I think one of the answers to the question about how does the community get involved is to participate in the insurance exchange, to participate in getting coverage. We have a population of young adults that are very much questioning, well, should I do this, should I not? There is this community effort, and the opportunity right now in Yamhill, certainly and across the state and the nation, is to get people signed up and enrolled so that healthcare costs across all populations, those with pre-existing health conditions, those elderly and aged that are going to definitely be more costly because of life stage. And part of the plan is to have the younger people come on and get enrolled. So I think there's a question for anyone listening about what's my responsibility in the health delivery system and how will I participate in this. And that's a personal question. We can't answer that for people. And at the same time, I think knowing that some of the solutions we're talking about should be accessible to other commercial populations, because commercial payers are going to follow suit, and they will start to see the value in preventative medicine and in looking at those larger social determinants of health, social, lifestyle, behavioral, and that health really is defined largely outside of the healthcare delivery system, and we need to look at that as a community.
And I might just add that kind of to dovetail off what Silas was saying, that the CCO really has kind of served as the platform for starting these conversations to, transform health in our community. It starts with the OHP members, but the relationships we're building between the hospitals, between different community organizations, between providers, those relationships, and then all the work they're doing, the projects like the community health workers or the care coordinators, the behaviorists, those efforts are slowly being extrapolated out to other members of the community that might be, a Medicare, that might have commercial insurance. So really the CCO, in my mind, has been the starting point for this, and it's just going to grow and continue to be successful and really kind of touch the lives of everybody that lives in the community.
Do you think that we can take the existing resources, this is just kind of your opinion I'm asking for, existing resources being expended on healthcare and reallocate them and more wisely spend them, or as we talk about changing the face of healthcare, is it going to take bigger buckets of money to throw at it? That's kind of just what do you think?
In a way, we kind of have already started reallocating how we pay for healthcare. As Silas and Jim were talking about, we're starting to move away from this volume-based system of care to a value-based system of care. So that kind of per member per month payment that primary care providers could receive to implement a team-based approach to care. That's kind of a new way of spending the healthcare dollars out there. Paying for a nutritionist, paying for a clinical pharmacist, paying for a behaviorist out of a monthly fee. You get to care for a patient, and maybe you don't, as a physician, need to see that patient every time they come in, but you're still receiving those dollars, and the dollars can be used to support the behaviorist and the nutritionist in seeing the patient. So
I think one of the things now, I'm not trying to make this a political show, but I'm going to ask your opinion if you're comfortable in giving it. One of the things that Silas was mentioning is your personal responsibility, and I think you know where I'm headed with this question. I'm going to give you an example. In New Zealand, when I was over there for 6 months, when you go and register your car, you can register it anywhere from 1 day to 1 year and drive your car that day, and it's registered, and you're good to go. But everybody in New Zealand who registers a car that's on the road, part of what they register for is health care. And so if you're an American citizen like I was driving in New Zealand, driving in a car on a New Zealand road, I got into an accident, I was covered because everybody paid into the pool. Okay, so the question that's happening now is a question of personal responsibility. All right, forcing people to pay. Now, we live in America. We like to have our freedom to make those choices. But in order to make sure that everybody is covered, everybody has to pay. So that gets kind of a political question here. Do you mind kind of stepping in that fray?
Well, I'd say everybody does pay for health care, whether you think you do or you don't, because
good point.
Taxes, your income tax, I mean, that goes to help pay for Medicare, Medicaid services. And then, patients or individuals right now that don't have health care insurance, they go to the emergency department, they rack up high bills that they can't pay for, then the hospital has to suck up those costs, and then what happens? Those costs get pushed down to other patients. Then, so the people that then do have commercial health insurance, probably pay higher rates because of other people not paying those bills. So I would say that we really are all paying for it, whether it's signing up for the driver's license and making you think you pay for it that way, or sending you a higher bill for going to the emergency department. If you're paying for it that way, I'd argue that we are all paying for this already.
Which is a more efficient way to do it.
Yeah, I think it's a efficient way where the people receiving the care, the patients, and then the people providing the care, the providers, and then the individuals actually paying for it, the payer, are involved with making smart decisions around it.
And I think what's happening right now is it's being made very political.
Agreed, and I think personally I would agree with Dr. Rickards that we're all paying for it, and whether you're a young parent without insurance, utilizing emergency room services and deferring those costs. Later as you become an adult and employed and have coverage, you're paying super, super high premiums to offset the costs of services that aren't being compensated at the hospital. So you either, pay for it early or pay for it later, but we are all paying for it. And I think, when I look back to at least my experience in the Southwest, when automobile insurance was first rolled out as a mandate,
right?
It used to be elective coverage years ago, and at one point there was a mandate that you have to carry liability insurance to protect the people that you might cause damage to. And I think we're starting to see the beginnings of policy that will help shape what the future looks like. I don't know that we're going to achieve that in 1 year, 2 years. Maybe 4. And I think healthcare reform really is going to be a multi-generational effort. But we're really starting some good work now. I think that will set the foundation for the future work to come.
Do you feel good about what's going on in Yamhill County, and is Yamhill County in some respects becoming a model for the state?
I think so. We get routine feedback from folks within our circles. I've traveled recently to the East Coast in September and bumped into an RN and had some conversations about healthcare reform. And very quickly she said, "You guys are doing great work in Oregon." So I think Oregon is getting a lot of attention on the national stage for its coordinated care model, and it's the first time in history that Medicaid is really leading the way in terms of change. Traditionally, it's the commercial payers that drive that change just based on the volume of people that they cover, and the tables are turning. And within Oregon, I think we're leading some really, really good work here locally with our new organization.
Yeah, and I would add that as far as us being a model, I think the model of bringing people together and forming those relationships is, probably the most valuable thing we can share. All healthcare is local. Different communities have different resources. Some communities might not have a hospital, or some communities might have, 4 or 5 hospitals. So I think, as far as the model goes, it's hard to take exactly what we've done and take it to another community, because they might not have access to behaviorists as we've had with, George Fox University here. But I think that idea of, just being willing to sit down, form relationships, and see what's available in your community and figure out how to make that work is an important thing.
Is there a website somewhere about the Yamhill Care Organization where people have heard this, they're intrigued, they like the philosophical change, like in a value-based system instead of a per-visit, an outcome-based pay model instead of every time I walk in the door I'm going to pay $125?
Yeah, absolutely. The Yamhill County Care Organization website is www.yamhillcco.org, and people can go there to look for information regarding our organization and the Oregon Health Plan population that we serve. And I think the Oregon Health Authority website would be a great source of information for people looking to get coverage, whether that's to confirm that they meet the eligibility requirements for Medicaid coverage or some other subsidized coverage.
One of the things we haven't talked about yet is prenatal care. Silas, you wanted to talk about that a little bit.
Yeah, well, one of the things I want to go back to, I'll touch on prenatal care.
Sure.
I wanted to go back to your question about, do we need more resources or do we have enough? Is this about redeploying existing? And I think the way that I think that's useful to think about is through this model for what's called collective impact. So Stanford has this model social innovation review that they've done research in this area, and they've basically boiled it down, the collective impact theory, to the following principles: that communities come together around a common vision, and they define that across public and private sector businesses. So they start to look at who has what resource available, whether that's a public entity, what are your regulatory frameworks, how do you have to work, what are your private sector dollars looking like, how's the nonprofits fit into this. And instead of being competitive, as many, if you think about social models for social care, nonprofits are often competing for the similar limited numbers of dollars, and there can be kind of cutthroat, and then you get government entities that have their allocations a different way and the red tape associated with that.
Yeah.
And so you come together and you define the common vision, and then you set these goals that we're going to work towards, and you measure yourself. Very key part of this is measurement towards the process of measuring towards goals. So it's really that when I hear Jim, Dr. Rickards and Jim Carlo talking here about value, it's being able to set the metrics and measure yourself towards those goals. So the collective impact model for us locally is a model that I think we're putting into place in a lot of different areas, and specifically we're working now further upstream into early learning. And the governor has put forward a bunch of different platforms for reform. Again, it's a political issue, and people may feel strongly one way or the other, but he's looking at public safety, education, and health as 3 areas of reform. And in the education sector, he's defined an early learning council and has created, through legislative process, an opportunity for communities to also form an early learning hub. In Yamhill, CCO is the only CCO in the state that went for an early learning hub, wrote a competitive application through the state, and has an initial notice of intent to award as one of 6 pilot communities across the state. We're really excited about that because it's specifically looking at prenatal care and then 0 to 6. And the focus there is getting kids ready to learn in kindergarten and then having better benchmarks at 3rd grade. Well, you might ask me, well, what's a community health plan? You guys have been talking about medical care and health care and health all this time. What's this got to do with it?
Well, now we're talking about education.
It has everything to do with it. We believe there is a strong nexus between health and education. And in order for us to have children ready to learn at kindergarten, they need some basic health services, and prenatal care is absolutely critical. It's one of the core CCO metrics, timeliness into prenatal care. It's one of, there are a bunch of measures about when a woman gives birth, whether it's early or not, and the types of prenatal care that she gets really influences the development of the fetus in the brain, and all of these later life functioning, there are tangible and research-based, scientifically proven outcomes that have to do with good prenatal care is really predictive of long-term health. And readiness to learn in kindergarten and the ability to create the future of our next workforce from an economic standpoint. So when you take this out really far, certainly healthcare costs are driving our national economic problems. And on the flip side, if we can redefine how we pay for services and redefine health and look at opportunities for better care from prenatal, from 0 to 5, really starting youngest and strengthening families and supporting our communities to bring those children into a better functioning education system, at some point we are talking about a local economic engine and really lifting people, eventually, potentially, lifting people out of a lifestyle of poverty and into a productive life that we would not have to have a public benefit of the Oregon Health Plan. So these are decades of evolutions we're talking about now. But I think we've got a board that's talking about, thinking about, and wanting to make these investments that are beyond medical care and really looking at the upstream indicators of the social determinants of health.
Yeah, I would just echo that, the importance of moving upstream. So often the sickest people that I see in my medical practice, in their 40s and 50s, they suffered either some type of trauma in their childhood or had some bad childhood experience, and that has kind of stuck with them and formed their physical health throughout their life. And I think that the story about of where this idea of upstream really kind of exemplifies this whole concept. And it's a story of these two guys are down on the Willamette River fishing, and one guy sees a baby floating down the river, and he throws on his pole, he runs out there, grabs the baby, brings it over to the shore, puts it down, and he looks out, and there's another baby floating down the stream. So he runs out there again, grabs the baby, puts it on the shore, and pretty soon he starts seeing all these other babies, and his fishing buddy takes off running upriver, and the guy starts yelling, "Hey, what are you doing? There's all these babies floating downstream." And he goes, "Oh, well, you can save these babies, but I'm going to move upstream and see why all these babies are falling in the river, and I'm going to stop that from happening." So, we're kind of that fishing buddy in a way that's running upstream to figure out why all these babies are floating on the river and trying to stop that from happening. So
good analogy.
Yeah.
So as we conclude the program here, how do you feel about where we're headed? You feel optimistic about the future, and then maybe a 60-second kind of encapsulation of where you are and what you're excited about going forward, and just maybe an overall situation. So what do you want to leave folks with? Silence, let's start with you.
So thanks again for having us on the radio. I think in the year ahead, we would like to do more of this, talk with the community, be out and be engaged, make sure that we're having conversations that are meaningful across the business sector, across health education, and that at the local level, more and more people are aware of the opportunities ahead of us. So from a county standpoint, I really think that we're fortunate to have the local elected leaders that we have. We have really great opportunities ahead of us to make sure that the people that we elect are representing the interests of the folks in the community that we are also serving, and that we're really strengthening at the grassroots level the ability to listen to the constituents that we serve. And I think the CCO reflects that, both from the provider base that we listen and work with and from the community that consumes the services. So I'm excited about that and want to support the good work of the community as it moves forward.
Jim Carlo, Executive Director of the Yamhill Care Organization.
I would have to echo much of what Silas says from a county standpoint and a public health standpoint. For me, it's continuing to keep the community engaged in this conversation, because that's where we really start to affect change and start to identify innovation. Innovation is going to help us get further upstream on some of these issues, as Dr. Rickards talked about, and I'm excited about the opportunity of this. I haven't seen this much innovation and change in healthcare, like I said, in the last 25 years, and this is exciting times for everybody. So to the extent that the listeners can get engaged either by getting coverage, determining whether or not they qualify for the Oregon Health Plan, and partnering with Yamhill CCO if that aligns for them, we welcome that, and I think we're going to see some great things in the years to come.
And finally, Jim Rickards, physician, local radiologist, board member, CCO, and also with Willamette Valley.
Yeah, so our organization just recently turned 1 year old, and I think we've been successful from the standpoint that we've managed to keep our spending under control. We're within our global budget, but then we're also seeing improved health outcomes. There's a set of metrics that we track regularly to measure our performance, and we're meeting the majority of those. And we're also seeing a decrease in emergency department utilization and an increase in utilization of primary care services. So we're starting to see the effects of the organization. We're starting to get more members connected to consistent care, to those preventative care services we kind of started out talking at the beginning of the program about. And I think just going forward, continuing those efforts, just continuing to foster relationships in the community, and looking at how we can, continue to innovate. And, one thing that I'm excited about is how can we leverage technology or bring in, digital health or telehealth in our community to kind of become part of that team-based approach to care, that we're trying to build and using technology as an additional tool in our toolbox, especially, with widespread use of smartphones and handheld devices now. There's so many opportunities out there to improve care and really develop what's called patient-centric care, where you bring the care to the patient in their setting without having to have them actually, make a trek to the doctor's office. So that's just one thing I'm excited about.
Okay. And if you want to hear this program again, it'll be on our website probably by noon today. Just go to KLYC.us, look for the YouTube link. It'll be the interview at the top of the page. And then as we do, one of the things we do here at KLYC is we do interviews on the street. Maybe we're down at the Kiwanis Club talking about the Tillamook cheese sale on 3rd Street. Or whatever we do, we post it on our website. So as we do more interviews, you might have to look down the page a little bit. But this interview will be up. As we do interviews, we never erase them, so they're in there for perpetuity. That's one of the cool things about YouTube, is there's no limit on how many interviews you can put up. So it's there, gentlemen. Thank you for being with us on Cup of Coffee this morning.
Great. Thanks for having us.
Thanks.
AM 1260 KLYC. We'll continue to watch the weather for you, and school situations, nothing new to report. It looks like maybe we're... the next bump we're headed for is about 1 o'clock this afternoon, when the possibility of freezing rain comes. We'll let you know. AM 1260 KLYC, and glad you're with us this morning. And back to the music.